one of our colleagues' net was not working, so I have stepped in. But we will this is a long presentation, but for today we will get to only about 15 minutes of it.
Rajiv, ও যদি এর পরে প্রেজেন্ট করে কখনো তুমি ওকে বলবে যে তুমি হাসপাতালে এসে প্রেজেন্ট করবে। ঠিক আছে, হাসপাতালে এসে প্রেজেন্ট করবে। হ্যালো।
So we will do it for about 15 minutes, and hopefully in future everyone will give us time to complete the full part of it. So in the next 15 minutes or so, we will we will try to cover some of these disorders. We'll start with something common, UTI and CACUT. CACUT, as we all know, is now the terminology for congenital anomalies of kidney and urinary tract. So this was a 9-month-old boy with came in with fever, lethargy for 5 days, and what we can see here is that definitely the white cell count is high. Apart from that, there is a lot of pus cells in the urine, so it is a UTI. But equally interesting is the creatinine, which is high, and what is more important here is that the potassium is very high and sodium is very low, and the child is acidotic. On ultrasound, we see that the child has a bilateral hydronephrosis, and if you can see my cursor, you can see that there are a lot of debris in the kidney, and these two are the ureter. Like in a normal ultrasound, you are not even able to see the ureter, but here you can see that they are hugely dilated. So we are dealing with a bilateral hydronephroureterosis in a boy. Newborn bilateral hydronephrosis, you already have the diagnosis, and that is posterior urethral valve. But the you might say that the metabolic acidosis is because of the AKI. Well, that might be contributing, but if we look at the anion gap, this will have a normal anion gap. So basically this child is having normal anion gap metabolic acidosis, and if you remember, that means renal tubular acidosis if the child is not having, say, diarrhea, ureterosigmoidostomy, etc. And if you further scratch your brain, then it will come out that normal anion gap metabolic acidosis with hyperkalemia is type 4 RTA usually. So basically this child is having type 4 RTA, and if you go through the various list of cause of type 4 RTA, then bilateral bladder outlet obstruction, sorry, not bilateral, like bladder outlet obstruction itself is a cause of type 4 RTA. So in this situation, all you have to do is catheterize, antibiotic, and hydrations, and that's what we did, and the antibiotic and it all settled down. And then we did a MCG, which you can see was a classical of a posterior urethral valve, and then this child got fulgurated. But another, so from this case, one important message was the fact that in bladder outlet obstruction, you can have a type 4 RTA, so low sodium, high potassium, and all it requires, rather than giving more of sodium, it requires is drainage and hydration, because that will correct the type 4 RTA. The other important message is this slide, that a story of posterior urethral valve never ends with fulguration. In fact, people say that it starts with fulguration because your bladder continues to create problem. And in fact, it has been seen that in almost half of these children with posturethral valve, in future they might go into CKD, chronic kidney disease. So they need to be followed up quite closely. Moving on to our next case, it was a 6.8-year-old girl with recurrent febrile UTI, came in with delayed walking, severe constipation, and the ultrasound showing bilateral hydronephroureterosis with thick bladder wall. This was the MCUG, and what you can see here is the classical neurogenic bladder. So a small bladder with out pouches, trabeculated, and a gross reflux. You can see that, so in the DMSA, it is the reverse image. So you can see this kidney here, and you can see the grossly dilated ureter, kidney quite damaged. So the clue is the delayed walking and the severe constipation, and nobody had bothered to look at the back. So this is the telltale sign of the tough here, and we know what we are suspecting. We did a urodynamic scan. If you have attended our bladder symposium recently, I'm sure all of you must be diagnosing this, that it shows that the bladder pressure is very high. And it is a neurogenic bladder with a high bladder pressure causing bladder damage, and MRI showing there is a neural defect, and it is a neurogenic cause. So and maybe if somebody had looked into the back and had made 1 + 1 2 with the delayed walking, maybe the kidney might have been slightly better. Moving on to another child. So the child presented with recurrent UTI with occasional dribbling of urine to us. Had a history of posturethral valve which was fulgurated at 2 months and refulgurated at 6 months. And again, if you had heard the bladder symposium, it is an established practice, at least in developed countries, that you have to have a recystoscopy. In India, it is often not done, but that's an established practice. But despite being fulgurated twice, this child went on to have repeated UTI. And because of this repeated UTI, had the ureter reimplanted. But this reimplantation did not solve the problem, and then they came back to us with the persistent repeated UTIs. And what we have is a very high bladder pressure. So what was the problem here was that the bladder was grossly damaged because of the posturethral valve. And if you do a ureteric reimplantation into this sort of a bladder without stabilizing the bladder, then this is what you will have. You will have the recurrence of the reflux, and your surgery will not work. So that's what happened. And ultimately, this child required ileocystoplasty and a mitrophenol, and after that was doing well. So this is an important take-home message, that never reimplant without a bladder workup. So often reimplantation can be a sort of a knee-jerk reaction. This was done in South India, where most of our family goes, and many of our doctors also refer to the South India. But then everywhere the doctors are, I believe, the same. So we have to keep in mind that never reimplant without bladder workup. So the UTI guideline by the ISPN, and till date, that's what it says, that less than 1 year you should have ultrasound, MCU, DMSA. 1 to 5 years ultrasound and DMSA. If either of them are abnormal, then MCU or DMSA. MCU plus minus DMSA, and more than 5 years for ultrasound. If ultrasound is abnormal, then MCU, DMSA. But remember, this is for the first UTI. If you are having a recurrent UTI, you will need all of them. I'll skip the tubular disorders because I think I had gone through this recently in ICH, and we will go to the next scenarios. Yeah, so we go to the rickets. 6-year-old girl with a bowed leg, multiple treatment with vitamin D, rate on the lower centile. Examination showed widened ankles and wrist along with genu varum. So what do we see here? We are seeing that the calcium is on the lower side, alkaline phosphatase is high, and the phosphate is very low. PTH is in the normal scale, and the vitamin D is normal. So hypophosphatemic rickets. Hypophosphatemic rickets, but the urine RE is normal in the sense it's not having any sugar. That sort of rules out Fanconi syndrome. We look for the loss of phosphate in the urine, and that can be done through a tubular reabsorption of phosphate or TMP GFR, and it confirms that the child is losing phosphate in the urine. So we are having a hypophosphatemic rickets from phosphaturia. What is the cause of it? Well, because it is not Fanconi, then the commonest cause remains the classical X-linked hypophosphatemic rickets, and we can confirm it with the help of genetic analysis. This was a child who came in with again rickets sort of a feature, again been given number of doses of vitamin D, but you can see here that has been transfused thrice. And I'll just tell you one report from this, and I'm sure most of you will be getting the diagnosis, particularly those from ICH. The phosphate is very high. So as I always say that there is almost only one disorder where you can have rickets with a high phosphate, and that is chronic kidney disease. So all you have to do is look at the creatinine, which was high. PTH, as you expect, will be high in CKD, and this was a rickets secondary to CKD. This one was a 3-year-old girl with a prolonged history of rickets. Now here you see, again, as they usually come to us after they have been given multiple courses of vitamin D and it has not worked. Here what we see is, classically we see is the 25 hydroxy vitamin D is high, but 125 hydroxy vitamin D is undetectable. PTH is also on the higher side. So if your vitamin D is high, but your 125 hydroxy vitamin D is undetectable, then most probably you are dealing with a defect where there is a in the transformation of 25 hydroxy vitamin D to the active form. So the VDDR type 1. And this one, courtesy Dr. Apurva sir, was here you see alopecia, and I'm sure all of you have already got the diagnosis, but the clue here is that 25 hydroxy vitamin D is slightly normal or sometimes the higher side, and the 125 hydroxy vitamin D is also on the higher side. So with alopecia, and you have got the diagnosis of the VDDR type 2. We have seen, we don't see in nephrology that commonly, but at least in my practice, I've seen 3 or 4 of them. This one is a very interesting case. I have presented it before in ICH and other meetings also. This is a child who we saw in ICH only, was in the general ward. So as you can see, florid rickets. You can see the rickety rosary and everything. You want to see in rickets along with the fractures, etc. Calcium was low, phosphate was very low, 1.4. Potassium was low, is 3.3. Bicarbonate was also low, 15. And the alkaline phosphatase was high. Because of the low bicarbonate, we did anion gap, which was normal. The urine anion gap was positive, and the TMP GFR and the TRP were suggesting of phosphate loss. And if you look, there was amino aciduria also. All this looks classically as a Fanconi, right? Why not? Because we have got rickets, we have got normal anion gap metabolic acidosis, we have got amino aciduria. So what else? We have got phosphaturia. What else do we want? Fanconi, what cause? We did look into the eyes. We did not see any signs of cystinosis. But the PTH was also high, and the vitamin D was quite low. So since we could not find any definite cause of this Fanconi syndrome, we said, okay, at least let us give vitamin D. So we gave vitamin D, nice dose, and lo and behold, once the vitamin D normalized or sort of went up and the PTH normalized, the TMP-GFR, TRP also improved significantly, and the amino aciduria disappeared. So what was the problem? Problem was that we often don't remember our textbooks, and if you look at the textbook, it clearly says that hyperparathyroidism itself can cause renal tubular acidosis, sort of a picture, can cause Fanconi. So we have to remember this. This was nothing exciting. It was a standard case of vitamin D deficiency. And this is the classical table which all of us have seen. I don't remember it at all, so I just carry it with me. Lastly, we will go through few cases of reddish urine and then call it a day today, or you can say night. So it was a 6-year-old girl, cola colored urine for 5 days, increased puffiness. History, there was no burning micturition, there was no systemic complaints as such. Blood pressure was on the higher side, and the urine RE did show proteinuria with some dysmorphic RBCs. So we have a diagnosis of acute glomerulonephritis. So with the acute glomerulonephritis, when we are suspecting, and in fact we have one in the ward just seen, not in the PICU, same sort of picture came in. What you do, the first thing that you do is look at the peripheral smear, make sure that you are not dealing with low hemoglobin, low platelets, and you look at the complements, the ASOs, and obviously do an ultrasound scan. So the C3 was low, ASO was borderline high, and all of this makes us more sure that we are dealing with post-streptococcal glomerulonephritis. So how do we treat post-streptococcal glomerulonephritis? Another very common question of mine. Post-streptococcal GN is the problem is with the hypertension, and hypertension is because of hypervolemia. So if you have to control the blood pressure in post-streptococcal GN, your line of management should be number 1, fluid restriction, number 2, salt restriction, and number 3, diuretics. So that's what it was done, and then after 10 days was off diuretics, antihypertensives was off, but the urine RE was still showing RBC. So remember that the RBC can persist. Microscopic hematuria can persist. It can even persist to a year and beyond. So not to be worried about microscopic hematuria, but if your proteinuria is persisting significantly beyond 3 to 4 weeks, then you start getting worried. So after 10 weeks, there was a 2+ of protein. So this particular slide shows what we have already said, that no, sorry, we haven't said this. This particular slide shows that your complement level should normalize in post-streptococcal GN. This was a study published by Matzel, one of the my mentors in Canada. So showing that complements usually normalize within 8 weeks. If your complement is still low after 8 weeks, then it is not post-infectious GN, or it is less likely to be post-infectious GN, and you are dealing with something else. It can be MPGN, the membranous proliferative glomerulonephritis, which is nowadays called C3 glomulopathy, or it can be something else like say infective endocarditis mediated GN, shunt nephritis, etc. But all of those will come with the history. But the MPGN is the most important DD and the SLE. And this can be differentiated by renal biopsy. For SLE, obviously, you will do a ANA. Next case, this is a boy with a fever for 5 days who came in with a reddish urine for 3 days under treatment with cotrimoxazole, and was referred to nephrology for the reddish urine, and had a low hemoglobin. So low hemoglobin, reddish urine, you'd think about and slightly high creatinine. 0.76 is slightly high. You'd start thinking about HUS, but there was no cystocytes and the platelet was normal. Urine dipstick was strongly positive for blood and protein 1 plus, and RBC said 10 to 12 RBC. Urine said 10 to 12 RBC per high powerful. Per cell was 10 to 12, and I'm sure many of you have already got the diagnosis. So here the red flag sign is that if your urine dipstick is strongly positive for blood, but your urine microscopy is not showing plenty of RBC, then most probably it is not hematuria. It might be hemoglobinuria or myoglobinuria. And in this particular cases, it was hemoglobinuria. The LDH was high, and then we did a malaria, etc. But ultimately, it all came down to had a GCSPD deficiency. Sorry, had a autoimmune hemolytic anemia. The DCT was positive. The other close, it could have been a GCSPD deficiency also, but its DCT was positive and was a autoimmune hemolytic anemia. So practically what this child was having is an autoimmune hemolytic anemia, from which the child had hemoglobinuria and then had a pigment nephrotoxicity. So the hemoglobin is toxic to the kidney, and we had a pigment nephrotoxicity, and what it requires is primarily conservative management. Now, this was another girl with a recurrent history of reddish urine. Now, in contrast to the previous one, where the microscopy was negative but dipstick was strongly positive, here the dipstick and microscopy, both of them were negative, as you can see here. Dipstick also negative for blood and microscopy also negative for blood. So this is not hematuria, this is not hemoglobinuria, this is practically it is a beetroot toxicity. So it was all induced from beetroot. So for what you call bituria, and other causes can be any sort of medications which can cause alteration in the color of the urine. This one, sort of a quiz diagnosis. 6-year-old girl awaiting for VHD, awaiting surgery, now recurrent episode of gross hematuria, febrile, and what you can see here is the splinter hemorrhage. So, infective endocarditis. This was published, this again from our institute only, and got published in Pediatric Nephrology. A child with a Wilson disease was referred to us for recurrent episodes of gross hematuria. If Subhamay is around, then he will be interested. So got referred to us for gross hematuria. Urinary, so blood was strongly positive and the RBC was plenty. So it was an actual hematuria. Dysmorphic RBCs was there. Now for the workup of dysmorphic for macroscopic hematuria, we did an ultrasound scan that was normal. We did the workup for the acute glomerulonephritis like complement, etc., which was normal. We did a calcium and then we did a calcium creatinine ratio, which was grossly elevated. So as we all know, hypercalciuria can cause hematuria. But why will a child with Wilson disease have hypercalciuria? So this was the hypercalciuria, 6.2 milligram per kilo per day of calcium in the urine. But why will a child with hypercalciuria, why will a child with Wilson disease have hypercalciuria? Further workup showed that this child had a normal anion gap metabolic acidosis and was actually having a renal tubular acidosis. So the hypercalciuria was secondary to distal RTA, and as most of us know, that Wilson disease is one of those disorders where you can have a distal RTA. So I'll sort of call it a night or evening now, and hopefully, like if interesting, then maybe I can be given future time to complete the other case scenarios. Thank you.
Rajiv, I've got a few questions. What is more common in Wilson's disease? Is it a proximal or distal?
দুটোই হয়, প্রক্সিমালও হয়, ডিস্টালও হয়।
More common is proximal.
Proximal, yeah.
Yes. So that's the message that I want to give, because for residents, it's more common in proximal. And second thing, did you do the workup for iron deficient in bituria patients? Because iron deficient patients, when they take beads, they cause more bituria. Did you do that?
Exactly.
Iron?
Yeah. This child was having iron deficiency, and we had started the child on iron supplement. But then
ওটা বললি না কেন? আমরা জেনে ফেলবো বলে, শিখে ফেলবো।
So